Memory loss, cognitive impairment versus Alzheimer's disease. As the global population ages, terms like cognitive impairment, dementia, and Alzheimer's disease have become increasingly common in medical and everyday conversations. While they are often used interchangeably in casual speech, they represent distinctly different medical concepts. Conflating them can lead to misunderstandings about aging, diagnosis, and treatment. Understanding the precise differences between a general decline in cognitive abilities and the specific pathology of Alzheimer's disease is crucial for effective care, early intervention, and managing expectations. 1. Cognitive impairment, the umbrella term. Cognitive impairment is a broad, descriptive term rather than a single specific disease. It refers to a noticeable decline in an individual's mental abilities such as memory, language, thinking, and judgment compared to their previous baseline. National Institute on Aging NIA, 2023. Cognitive impairment exists on a spectrum. Mild cognitive impairment, MCI. The individual experiences cognitive changes that are noticeable to themselves or others, but these changes do not significantly interfere with their daily independence or ability to function. Peterson et al., 2018. At this stage, changes are usually confined to memory and thinking, losing a train of thought more often than before, needing extra time to plan a familiar task like paying bills, or forgetting a recent appointment and needing a reminder. Personality and behavior are generally intact, and the person can still live alone, manage their own finances, drive safely, and hold a job. Severe cognitive impairment, dementia. When cognitive decline becomes severe enough to disrupt daily life, social interactions, and basic self-care, it crosses the threshold into dementia. World Health Organization WHO, 2023. At this stage, symptoms typically appear across two distinct domains, and it's the combination, not just the memory loss, that families usually notice first. 1. Cognitive and memory symptoms. Recent memory loss, forgetting things that just happened, a conversation from an hour ago, or what day it is, while memories from decades past may remain vivid and intact. Disorientation to time and place, losing track of the year, season, or time of day, getting lost even in familiar surroundings. Loss of familiar skills, suddenly being unable to operate a TV remote used for years, forgetting which bus to take on a routine trip, or being unable to manage a checkbook that was handled easily before. Language difficulty, struggling mid-sentence to find the right word, or repeating the same sentence or question over and over without realizing it's been said already. 2. Behavioral, personality, and emotional changes. Suspicion and paranoia, because gaps in memory go unnoticed by the person experiencing them, they may accuse others of stealing belongings or become convinced that a close family member is trying to deceive or harm them. Emotional volatility, sudden anger or distress over something minor, a misspelled word, a moved object, sometimes escalating to shouting or physically aggressive behavior that would have been out of character before. Social withdrawal, losing interest in hobbies once enjoyed, avoiding social gatherings, or preferring to stay home rather than go out as they used to. Loss of social judgment, behaving in ways that ignore normal social boundaries, for example, calling someone in the middle of the night without any sense that the timing is inappropriate. The first domain reflects the cognitive decline most people associate with dementia. The second is just as common but often mistaken for a personality change, a mood disorder, or simple stubbornness rather than a sign of the underlying disease. Families are often more disturbed by the behavioral changes than by the memory loss itself, since they can feel like the person isn't themselves anymore. Crucially, cognitive impairment is a symptom or state of brain function that can be triggered by a vast array of underlying causes. Some of these causes are progressive and irreversible, while others are entirely treatable. Non-Alzheimer's causes of cognitive impairment include stroke or vascular damage, traumatic brain injuries, severe vitamin deficiencies, such as vitamin B12, thyroid imbalances, chronic sleep apnea, and medication side effects, Gale et al., 2018. 2. Alzheimer's disease, a specific neurodegenerative pathology. In contrast to general cognitive impairment, Alzheimer's disease, AD, is a specific, progressive neurodegenerative illness. While it is the most common cause of severe cognitive impairment, accounting for an estimated 60% to 70% of all dementia cases globally, WHO, 2023, it is a distinct disease entity characterized by unique physical changes in the brain. The pathology of Alzheimer's disease is defined by two primary biomarkers: amyloid plaques, abnormal accumulations of the beta-amyloid protein that clump together between neurons, disrupting cell-to-cell communication; tau tangles, abnormal accumulations of the tau protein that build up inside neurons, destroying the cell's internal transport system and leading to cell death. Alzheimer's Association, 2024. Alzheimer's is a disease, not a life stage. This point is worth dwelling on, because it is the single most common misconception the public holds about memory loss. Advanced age is the strongest known risk factor for developing Alzheimer's, but a risk factor is not a cause. Millions of individuals live into their 90s and beyond with completely intact cognitive function, which demonstrates that aging alone does not produce the disease. NIA, 2023. Something specific has to go wrong at the cellular level, the buildup of plaques and tangles described above, for Alzheimer's to take hold. Getting older makes that cellular cascade more likely, but it does not make it inevitable. The reverse is also true. Alzheimer's can appear well before old age. A small percentage of individuals develop early onset Alzheimer's in their 40s or 50s, and these cases are often driven by identifiable genetic mutations rather than by the accumulated wear of aging. Alzheimer's Association, 2024. For someone with a strong family history of early onset disease, this genetic link is often the reason a doctor will recommend genetic counseling or testing, a very different conversation than the one had with a typical late onset patient, where genetics play a smaller, more probabilistic role. 3. Divergent treatment pathways. Because cognitive impairment and Alzheimer's disease have fundamentally different root causes, their treatment strategies diverge completely. The clearest way to see this is by contrasting what each treatment is actually trying to fix. Treatment for Alzheimer's disease, targeting the pathology itself. Alzheimer's treatments work directly against the structural brain damage described above, either by attacking its physical cause or by compensating for the neurons it has already disabled. Disease-modifying therapies attack the root pathology. Monoclonal antibodies such as lecanemab and donanemab bind to and clear amyloid plaques from the brain, delivered via clinical 4 infusions or, more recently, via at-home subcutaneous autoinjectors. The FDA approved a subcutaneous autoinjector option for lecanemab, Lecm in 2025 to 2026, allowing eligible patients to self-administer weekly doses at home instead of returning to a clinic for infusions. These therapies slow, though do not stop, the rate of cognitive decline, but only for patients strictly in the earliest symptomatic stages of the disease. They are approved for mild cognitive impairment or mild dementia due to Alzheimer's, not for moderate or severe stages, where the structural brain damage is already too extensive for plaque clearance to meaningfully help. Van Dyke et al., 2023. Symptomatic medications work around the pathology rather than against it. Cholinesterase inhibitors, such as Donepezil, boost the levels of neurotransmitters that surviving neurons still need to communicate, temporarily supporting memory and thinking without changing the underlying disease course. Gale et al., 2018. In both cases, the goal is to manage a condition that cannot currently be reversed or cured. Treatment for other causes of cognitive impairment, correcting the underlying trigger. When cognitive impairment stems from non-Alzheimer's origins, treatment does not target brain pathology at all. It targets whatever metabolic, vascular, or pharmacological problem is producing the symptoms. Because there is no structural damage to manage, many of these interventions can halt or entirely reverse the decline. Metabolic and nutritional correction: a severe vitamin B12 deficiency or a thyroid malfunction can be identified with a blood test and corrected with supplementation or hormone therapy, often restoring cognitive function fully. Gale et al., 2018. The word severe matters here. The ordinary, mild fluctuations in B12 levels that many people have won't produce dementia-like symptoms. It's a pronounced, sustained deficiency, often from pernicious anemia or malabsorption, that reaches the threshold needed to affect cognition. Vascular management: when impairment stems from minor strokes or reduced blood flow, vascular dementia, treatment focuses on aggressive blood pressure control, cholesterol management, and lifestyle changes to prevent further tissue damage, protecting what function remains rather than reversing what's lost. Medication review: if cognitive symptoms are a side effect of sedatives, anticholinergics, or polypharmacy, a physician-guided adjustment of the prescription regimen can resolve the confusion completely. The practical takeaway is that a reversible cause, correctly identified, can be fixed at its source, while Alzheimer's, once diagnosed, can only be slowed or managed. A note on overlap: these categories are a useful simplification, not a strict partition. It's common for an individual, especially an older adult, to have more than one contributing cause at once, such as underlying Alzheimer's pathology alongside vascular damage from small strokes. This is often called mixed dementia. Its existence doesn't undercut the symptom versus cause framework above, it just means a full diagnostic workup should look for all plausible contributors, not stop as soon as one is found. Conclusion: ultimately, the relationship between cognitive impairment and Alzheimer's disease is one of symptom versus cause. Cognitive impairment acts like a medical signal, a warning that the brain's processing power has been compromised. Alzheimer's disease is one specific, irreversible condition that can produce that signal, strongly influenced by age but ultimately driven by distinct cellular pathology. Recognizing whether a patient's cognitive decline stems from Alzheimer's or from an alternative, potentially reversible condition is the vital first step toward securing the correct treatment pathway. References: